Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here on the beautiful Central Coast of California. Thanks very much for joining me today. I'm delighted to have you with us, and I am delighted to have the very esteemed Dr. Hugh Wilson as my first guest. Dr. Wilson, pathologist, thanks very much, surgical pathologist.
That's correct.
Thank you very much for being with us today.
Thank you for having me.
Dr. Wilson, before we get on to our very important topic, colon cancer, that I want to talk about today, let's give a little background about how someone becomes a surgical pathologist and what your week is like. For example, you went to medical school and you did residency, so tell us a little bit about that.
So, like all doctors, people in the military say you're a soldier first and you're a radioman second, or whatever your MOS is, right? In medicine, we're a physician first and then you're a specialist second. So, college, medical school, internship, and then residency is where I specialized in pathology. And the typical pathologist in practice, medical practice today, does both surgical pathology and clinical pathology, which is the laboratory. But both of them, what they have in common is that it's not a specialty that's built around an organ system. It's a specialty that's built around a series of techniques, diagnostic laboratory techniques to diagnose medical conditions.
Okay, so Dr. Wilson, I recall from, I think it's Latin, pathos means, well, it's pathology means disease. Essentially, there's something wrong.
That's correct.
Pathologic, that's where we get the term pathological. There's something wrong or deranged. And so I think technically the pathologist, the ogist part of pathologist means the studier of disease, correct?
That's correct. Pathology is the study of disease, as opposed to, so for example, anatomy is normal anatomy. What is the normal human anatomy? Whereas pathological anatomy would be abnormal, diseased anatomy.
Got it. So Dr. Wilson, before we get into talking more about the specifics of colon cancer, what's your week like, a surgical pathologist? What do you wake up in the morning and do?
Well, the first thing I do is panic. No, just kidding. So typically, my day begins with receiving specimens. So surgeons and gastroenterologists and other physicians who have seen patients and have decided that that patient needs a biopsy or an excision, they then send it to the laboratory. They send it to the laboratory in a preservative, and then that tissue can be processed into a small slide, which is a very thin piece of tissue that we can actually pass light through. We use transmitted light. So the light that comes through the tissue is then focused by the microscope lens onto the eyepieces, so we can see a magnified view of the tissue. So the process is we receive the tissue, we make sure it's adequately preserved, we process it so that it's firm enough to be sliced thin. Then after it's sliced, we stain it to highlight details, and then we can look at it under the microscope. And the day goes on with routine specimens that come in that way, and then specimens that need to be evaluated right away in the operating room, so that the surgeon knows how to proceed with his operation.
Okay, so you do a lot of examination of tissue under the microscope.
Yes.
And you're giving feedback to the doctor and the team, and then, of course, the patient about what you see under the microscope.
That's correct.
And Dr. Wilson, this is actually a perfect segue into talking about colon cancer and polyps and benign tumors as opposed to malignant tumors. So in our previous episodes, you've taught me a lot, and we've taught the audience, I hope. For example, if we look at the skin, everybody knows what a mole is. The medical term is nevus. Now, not every mole or nevus is a malignant melanoma.
Correct.
And all over the body, many people have heard about lipomas. That's a benign fatty tumor. It's still a tumor, but it's a benign tumor of fat cells.
Right.
Now, there's also something called a liposarcoma, which is a fatty tumor, but that's malignant.
That's correct.
Now, we know that in the colon, we can have a benign polyp. I think they're actually quite common. But some of those polyps are not benign, they're malignant, which means they're cancerous. So how do you, as a surgical pathologist, when you're given a specimen, let's say the gastroenterologist does a colonoscopy and then a polypectomy, which the gastroenterologist will remove the polyp. Now, how do you tell whether or not that's a benign polyp or a cancerous growth, a cancerous polyp? What do you look for? How do you know? Just by looking under the microscope.
So the features that would distinguish, that a tumor is simply an abnormal growth, and as you said, it can be benign or malignant. Benign tumor, it might press up against the surrounding tissues, but it does not invade the surrounding tissues, and it doesn't spread anywhere. A malignant tumor will do those two things. It will invade surrounding tissues, and it can spread to other points in the body. That invasiveness is something we look for under the microscope. So, the tissues are made up of cells. So when we're magnifying the tissue under the microscope, we're looking at individual cellular features and then also how those cells arrange themselves into a tissue. And so malignant tissues will show invasive behavior. They'll invade into the surrounding tissues. Now, one of our hopes, though, let's stick with the colon cancer and the endoscopy, the colonoscopy that the gastroenterologist does. He's using a flexible fiber optic microscope, basically, to look at internal tissues and identify a polyp, which is a growth up above the surface of the colon. And when he takes that out, the hope is what he's going to find is that a tumor that's not yet invasive. Because if it's not yet invasive, it's completely curable. So, but for me, if it's not invasive, how do I tell it's malignant? It's the way those cells arrange themselves to one another and the things they stop doing. In the colon, for example, colon epithelial cells, the lining cells of the colon, typically make mucus, which is a slippery substance that helps the food particles pass through. A malignant tumor or a pre-malignant tumor will stop making mucus. And then the cells will have an abnormal arrangement. So instead of being layered across the bottom layer of the epithelium, they will start to grow upward. And in a benign condition, they respect each other's space. In malignant, they don't. They start piling up on top of each other and invading each other's space, as it were. So there are ways that the individual cells react to each other. And then within the cell, that a cell has, it's the smallest unit of life, right? It can reproduce itself, consume energy, and produce waste. And it's contained by a membrane, and then it has a semi-liquid central portion called the cytoplasm, and another unit called the nucleus, which is sort of that's where all the information on how the cell should operate is contained. A benign cell has a relatively low ratio of nucleus to cytoplasm, whereas a malignant cell has a higher ratio of nucleus to cytoplasm. So there are tissue features and there are cellular features.
Okay, so Dr. Wilson, once again, so the gastroenterologist does a polypectomy, for example, biopsy, and you get the specimen, and then you do your preparation and you can look under the microscope. But what about in cases where it looks like there's some what we call cellular atypia? Like there's some of the nuclei look unusual, some of them don't. Aren't there special stains and special markers that you can perform, like little almost biochemical tests that you can perform to distinguish between a malignant cell and just a benign, highly proliferating cell, like in a benign polyp? Are there markers or special stains you can do?
Yes, well, one of let's say for invasion, for example, if we're suspecting some very early invasion, the bottom layer of the epithelium, the lining of the colon, has what's called a basement membrane. We can stain that and see if it's we have a stain that will highlight that, tell us if it's still intact. We can also, for example, if there's I said that the malignant cells stop making mucin, we have stains that can highlight mucin to see how much is there versus is it a normal amount, is it a decreased amount, or is it absolutely gone? Once we think that there is perhaps a malignancy there, we have other markers we can use to see what kind it is.
Okay, so Dr. Wilson, you've taught us in other areas of the body, for example, with lung cancer. We've spoken about how chronic inflammation, whether it may be chronic smoking, that irritant from the smoke, maybe air pollution can irritate the bronchial lining, and that can bring about a malignant change. And those cells can go elsewhere. In other words, they can break off and go elsewhere, and you've called that metastasizing. Isn't that correct?
That's correct.
So for example, in the colon, or almost anywhere in the GI tract, the stomach, esophagus, small intestine, large intestine, the colon, when the cells are malignant and some break off, they can go to other parts in the body and take root. Isn't
Yes.
that correct?
Yes.
So that's a much more advanced cancer. The stage, if we were to stage the cancer,
Yes.
that would be much more advanced.
Yes.
So how do you help the gastroenterologist and the oncologist with the so-called staging of a tumor? How do you help with that?
So the the earliest stage would be completely confined to the lining layer of the colon, right? And we can see that even on an endoscopic biopsy, the biopsies that are done at colonoscopy or esophagogastroduodenoscopy from above. We can see if it's confined to the superficial layer. Now, if it has invaded below that, that's sort of difficult to see until there's been a surgical excision. But at the time of the surgical excision, we can see how deep through the layers of the colon has the tumor invaded. We can also then, the surgeons will take out, in addition to the colon, some of the surrounding tissues that attach the colon to the peritoneum. And within those tissues, there are lymph nodes. And that's typically the first place that a cancer would metastasize to. So we can find the lymph nodes, examine them, see if any of them have cancer, and if so, what proportion of them have cancer.
Okay, so you've taught us that one of the characteristics of a malignant tumor as compared to a benign tumor. So a benign tumor might grow incredibly large.
Yes.
I've seen lipomas as a plastic surgeon that are huge, but they push the tissue adjacent kind of aside and continue to grow. A malignant tumor will actually invade, isn't that correct?
That's correct.
Like those cells grow into the adjacent tissue, as well as one or two cells breaking off and taking root somewhere.
That's
Isn't that correct?
Yes. So like a benign tumor that might push up, it'd be like if your neighbor widened his driveway, so he's on your property, but he's not really hurting you. It's another matter if he starts throwing rocks at your house and breaking your window and coming on inside. That's what a malignant tumor would do. A benign tumor might just take up some space in your yard, but a malignant tumor breaks the window and climbs in. It's invasive. And then, as you said, distantly, it can get into either the lymph system or the blood system and travel to distant sites. Now so we can help the gastroenterologist or the oncologist with that as well, but it typically takes a biopsy at that other site. From the surgical excision of the tumor, I can see the depth of invasion in the wall of the colon and any metastases to associated lymph nodes. Distant metastases, say for example to the liver, I would also need a liver biopsy to determine if there's cancer there.
Okay, so Dr. Wilson, that's another key point. Now we know, for example, plastic surgeons, we take care of a lot of breast cancer. So we know that when the breast cancer goes somewhere else, it may continue to grow locally within the breast. It could go to the lymph nodes. The first lymph node it goes to, we typically call the sentinel node.
Right.
But when we can predict if it's going to break away, it goes to certain predictable spots.
Typically.
Right? As I recall, breast goes to liver and bone and brain, I think. So,
yes.
Where does colon cancer go? Can we predict where it's going to metastasize to?
Yes.
If it's going to?
The most common site for it to go to is the liver.
The liver.
By far, but it can also go to other spots as well. It can go to the lungs. But by far the most common site, other than lymph nodes, would be to go to the liver.
Okay. So Dr. Wilson, one very important role I think we can play in educating the public. We've talked about some scary terms, malignancy, metastases, colon cancer, but I want to emphasize that much of the work that you do will be diagnosing a polyp that is cancerous, but it hasn't gone anywhere. It's totally and completely curable, but you can help the gastroenterologist and oncologist stage it and grade it and teach the patient about what they have or had, and the patient is totally and completely cured. Isn't that correct?
Yes, that's
so
correct.
so because I think what we need to do is emphasize, because the person has a polypectomy and a biopsy and a pathologic exam, that doesn't mean that it's threatening to their life.
No, and that's there are multiple purposes for colonoscopy. Screening colonoscopy as opposed to diagnostic. Screening colonoscopy is a completely healthy person who comes in to be checked, just in case, right? And so there's a couple of goals. One is early diagnosis, right? We know with all cancers, the earlier you find it, the better the prognosis, the more likely the patient is to have a good outcome. If it's found early, it's much more treatable. And then the second goal is, if you find one of those pre-malignant or actually malignant polyps, but it's still confined to the lining layer, well, that's curative. It's actually preventative. So colonoscopy is both early diagnosis and prevention. By taking that polyp out, it will never become cancer. It'll never invade and it'll never spread somewhere else. It's one of the best things that adults can do for themselves, is to go for their screening colonoscopies.
Well, Dr. Wilson, that's great information to emphasize. I appreciate that very much. Now, you also mentioned EGD, I think.
Yes.
The gastroenterologist not only does colonoscopy, and you assist with analyzing and doing biopsies of polypectomies, removing polyps, but he may oftentimes, the gastroenterologist, he or she may biopsy an esophagus that looks unusual, may biopsy a stomach lining that looks unusual. Isn't that correct?
Yes, that's correct.
So you can help with distinguishing between esophagitis or Barrett's esophagus, or a malignant tumor of the esophagus, or lining of the stomach. Isn't that correct?
Yes, that's correct. And also the first part of the small intestine, called the duodenum. The gastroenterologist will also look there and sample there. People have heard of celiac disease or gluten sensitivity. They can sample the first part of the small intestine, called the duodenum. In the stomach, if someone has gastritis, the biopsy can be used to determine if they have an infection, a bacterial infection with Helicobacter, which can be treated with antibiotics and can make the gastritis go away. And then again, also for ulcers and for tumors. In the esophagus, they can biopsy for tumors or a pre-malignant condition called Barrett's esophagus, or Barrett's metaplasia. Metaplasia being a normal tissue in an abnormal location, but which can predispose to cancer.
Well, Dr. Wilson, I really appreciate you coming on and teaching us a lot. We only have a few seconds. I have one more question for you.
Sure.
Oftentimes a patient, after undergoing a procedure with the plastic surgeon, will sit in the office afterward and talk about the results and counsel them about the future, and they'll oftentimes come into the gastroenterologist and sit and talk about what the biopsy showed. I wonder if a patient is interested in sitting with the pathologist and, say, looking at the slides. Is that possible, that you could actually sit with a patient and teach them what their biopsy shows?
Absolutely. We do it upon occasion. It's not that common because typically there's at least one doctor between us and the patient. So, for example, the patient sees his primary care provider, who sends him to a gastroenterologist who does the biopsy, and the patient seldom takes the effort to schedule an appointment with the pathologist. But it does happen, and we're always happy for it.
I think it'd be very interesting, I think, to sit with people and teach them about what you see under the microscope.
Yes.
Dr. Hugh Wilson, surgical pathologist, we're lucky to have you here in Monterey County on the beautiful coast of California. Thank you very much for being here, and I hope I can convince you to come back and be a guest again.
I love it, Dr. Morwood. I'll be back anytime you like.
Dr. Hugh Wilson, surgical pathologist. Once again, I'm Dr. David Morwood. This program is the Doctor Is In television program. I'm a board-certified plastic surgeon right here in beautiful Monterey, California. We're going to take a very brief pause for a very good cause. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline. Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here on the beautiful Central Coast of California. I'm delighted you could be here with us, and I'm delighted to welcome on as a guest Dr. Daniel Luba, gastroenterologist, very esteemed guest. Dr. Luba, thanks very much for joining us.
Thank you for having me.
Dr. Luba, I am delighted you're here. I'm so interested in learning more about gastroenterology and colonoscopy and EGDs and what a week is typically like for a gastroenterologist. And then we're going to segue into colon cancer, which I know you are an expert in and you can teach us a lot. So let's get started a little bit. Tell us about yourself. Let's start with where you grew up and you went to high school and then where'd you go to college and medical school, etc. Tell us about yourself.
So I grew up in New York, and then I went to college, but sort of different from most people, I went to a 6-year medical program. So from high school, I applied to this program and I got accepted to both college and medical school at the same time.
So you're a boy wonder.
Well, I just got lucky and got into a shorter program.
So where in New York, Dr. Luba?
A place called New City, New York. It's just north of the city.
Just north of the city. I'm blessed and lucky enough. I started my training at Beth Israel and Mount Sinai before I headed to Paris and London and Los Angeles and then to Monterey. So where did you go to medical school?
At Boston University.
At BU. So that was a combined program.
Right.
So you went from high school to a 6-year program, combined college and medical school.
Correct.
And then where from there?
And then I did my residency at the Boston VA and then my fellowship at Stanford.
Okay, excellent. So your fellowship, so I want to teach our audience that, so when we say residency, that's sort of like, well, those are the years right after internship or after medical school. And then your fellowship, that was a subspecialty, correct?
Correct.
So your residency was in gastroenterology.
Residency was in internal medicine.
Of course. So you were fully trained in internal medicine. So you could have opened an office. Hello, I'm Dr. David Morwood. And they know who I am. They know I'm Dr. David Morwood. So you could have gone on to be an internal medicine doctor.
Correct.
But instead you went on to gastroenterology and specialized.
Yes.
So tell us what your typical week is like. What is your week as a gastroenterologist like?
Well, as a gastroenterologist, one of the things that's I enjoy the most about it is that it's very varied. So I see patients in my office and we'll evaluate them and try to figure out what's going on, make diagnoses, treat their different GI problems. I also cover the hospital, so I'll see emergencies in the hospital if people come in for something that requires hospitalization. I also do procedures where we'll do colonoscopies, upper endoscopies, things like that. And then in addition, because I'm in private practice, I manage my practice as well. So there's a very varied, there's a lot of variation to the practice.
And Dr. Luba, you're an incredibly accomplished person, and I just want to give a little hint. Our next segment, and I'm hoping you're going to have time to stay for another segment, you have a project going on related to the genetics and DNA of colon cancer. and that's a project that you've invested a lot of your own energy into, and we're going to be able to talk about that next segment. I hope you have time to stay.
Sure.
So, a big topic in the news now is cancer, and can we prevent cancer, and how do we get cancer, and I think maybe heart disease is the most common killer of adult Americans, but cancer I think is number 2. So let's talk about something like cancers of the GI tract. They seem to be relatively common, unlike, let's say, a primary bone cancer, or fortunately, brain tumors are not that common. But it seems like everyone knows somebody who's gotten colon cancer or maybe an esophageal cancer. What is it about maybe the lining of the GI tract and the oral pharyngeal digestive tract? What is it about that lining that is susceptible to cancer? Why do gastroenterologists see so much cancer?
It's a real good question. It's hard to know for sure what all the cancers are, but certainly there's environmental factors. The GI tract, the lining turns over. It reproduces itself very, very quickly. So with the constant replication of the cells in the GI tract, it's prone to making errors. And if you make errors when the cells divide and reproduce, then there's a better chance of having a tumor. Plus, it's being exposed to things in the environment all the time. And some of the things that it gets exposed to are not the best things for the cells. So I think when you look at environmental factors, the fact that it turns over so quickly and so frequently probably puts it at a little bit more risk. The brain, for example, is relatively protected.
Right. Well, Dr. Luba, in my specialty, plastic and reconstructive surgery, we know that chronic inflammation over the course of many years will lead to a higher incidence of degenerating cells, which can become cancerous. For example, a person who bakes in the sun, although it may feel great, those UV rays coming really cause chronic inflammation. Mm-hmm. We know that smoking, a chronic irritant to the lung and to the bronchioles, can cause lung cancer. Now, is there an equivalent in the GI tract where chronic inflammation can lead to degenerating cells, which leads to cancer?
Sure, and actually there are several, but in the colon, there's ulcerative colitis and Crohn's disease, where there's a chronic inflammatory state, and then because of the inflammation, it predisposes to cancer. And in the upper GI tract, if you have chronic reflux, people can sometimes get what's called Barrett's, where the lining of the esophagus starts to change and look more like the lining of the small intestine. And in some ways, that's a protective change because the small intestine is more used to seeing acid, whereas the esophagus shouldn't. It also predisposes to developing cancer.
Okay, so I think that's important to emphasize, that there are conditions that lead to chronic inflammation, say chronic reflux or ulcerative colitis, or maybe gastritis, hyperacidity in the stomach, leading to chronic inflammation of the lining that can predispose someone to carcinoma. But Dr. Luba, in terms of public health, this is a key lesson, I think, our take-home lesson. When those issues and conditions are treated, isn't it true that we can almost eliminate the increased incidence of cancers developing?
Sure, and if you look at gastric cancer, stomach cancer, where that, especially in Asia, was caused by the H. pylori bacteria. If we treat the H. pylori, the H. pylori bacteria causes a chronic gastritis, so chronic inflammation in the stomach. If we treat and get rid of that bacteria, we can decrease the risk of getting gastric cancer.
Okay, now see, that's fascinating to me. So let's take a couple minutes to digress. Let's teach our audience what we mean by that. H. pylori and an H. pylori infection leading to gastritis or an ulcer. Let's teach the audience what we mean by that.
So H. pylori is a bacteria. It's lined the GI tract, or the stomach specifically, for ages. It's typically found in countries with poorer sanitation. So if you go, before the sanitation got much better, almost everybody was infected with this bacteria. And we didn't even really think there was much to it. As our sanitation has gotten better, it's decreased in the incidence. So in the United States, we don't see it as much. Maybe about 20% of 15 to 20% of people our age in the United States would be infected with the H. pylori bacteria, whereas, 30 years ago, that might have been 70 or 80%. If you go to Mexico, probably about 80 to 85% of people are infected. And it's also very common in Asia. And especially in Asia there, because of that infection, that low-grade bacterial infection that's just sort of chronic, it can predispose to ulcers, and it can also predispose to cancer.
Okay, so, and I want to emphasize that it's treatable, right? Or can we say it's curable? I mean, that can be treated.
Well, usually you get it when you're very young, and usually it stays with you all your life. If you get treated with antibiotics, it can get rid of the bacteria, and then it's cured. Now, so you eliminate that risk factor.
Okay, now are there signs or symptoms? Like how would someone know if they have the contamination or infection of H. pylori?
Well, oftentimes they'll have not so much the problem of the infection with the bacteria itself, but it's the problems that the infection can cause. So if you get pain in your stomach, burning pain, ulcers, things like that, the H. pylori bacteria infection predisposes you to getting ulcers. So if you have an ulcer or ulcer symptoms, then you can get tested.
Okay, that's key. So if someone has frequent reflux, dyspepsia or heartburn, if someone has symptoms of an ulcer, pain in their stomach that goes on for a while, I think one of the take-home lessons is get it worked up, see your doctor.
Right, and one of the standard things to do early on, especially for pain in the stomach, is to check and see if you have that bacteria, because if we treat the bacteria, the pain oftentimes goes away.
Excellent. Okay, so Dr. Luba, that's the upper GI tract, the esophagus and the stomach. Now we talked briefly about conditions like ulcerative colitis, Crohn's disease, chronic inflammatory conditions that can predispose to chronic inflammation that may predispose a patient to forming polyps or even colon cancer. Isn't that true?
Mm-hmm.
So what are some of the signs or symptoms that a person may have one of those conditions, like ulcerative colitis or Crohn's disease, etc.?
So for ulcerative colitis and Crohn's disease, the typical thing that people have is diarrhea. And oftentimes there's blood associated with it. So it's usually fairly obvious that there's something wrong. Everybody gets diarrhea on occasion. That happens. But when the diarrhea lasts for more than a week, 10 days, certainly 2 weeks, there's something wrong. And then you start looking and saying, what else is going on here? If you have a bout of diarrhea, lasts a couple days, goes away, that just happens.
Okay. So, which is a perfect segue into my next question. When we say see your doctor or see your gastroenterologist, probably for most adults, if they have symptoms of diarrhea, chronic inflammation, bleeding, etc., probably they're going to get a recommendation to get a colonoscopy.
Mm-hmm.
So teach us really what colonoscopy is, how is it done, what are you looking for, the mechanics of it, do they have to stay in the hospital, is it outpatient, does insurance cover it, how long does it take? So teach us about colonoscopy. Give us an introduction, please.
So colonoscopy is basically a way to look at the colon. So we use a scope. It's about the size of my pinky. It's flexible, bends around corners, has a camera at the end of it, and projects a picture up onto a TV screen. So to prepare for a colonoscopy, basically a person has to be on clear liquids the day before the procedure. So a clear liquid is anything you hold to the light and see through. So like tea, broth, apple juice, lemonade, you hold it to the light, you can see through it, that's fine. But stuff like milk or orange juice, you hold it to the light, you can't see through it, that's no good. So clear liquids the day before. In the early evening, you drink the first part of your prep that will give you diarrhea and clean you out so we can see. Now, the second part of it is that the next morning you have to drink another part of the prep. And it's real important to split the dose, and we found that out over the last 10 years or so, because oftentimes we were getting kind of poor preps in the right side of the colon. And what happens is the small intestine during the evening makes this thick, sticky substance called chyme, and that coats the right side of the colon. So it's that second morning dose of the prep that gets rid of that and enables us to see the subtle polyps.
Okay, so Dr. Lu, I just want to make a teaching point for one moment. When you say the right side of the colon, we know that it's the esophagus, goes to the stomach pouch. There's an actual anatomic structure, the stomach, which becomes the small intestine, and there's three parts to the small intestine, right? It's the duodenum, the jejunum, and the ileum. Medical school is some years away, Dr. Luba. And then we get to the colon, right, the cecum. And so when you say the right part of the colon, that's the ascending colon, correct?
Yeah, the cecum and ascending colon.
Okay.
So if you just think about your body, right? The right side of the colon is right here. The transverse colon goes here. And then you have the descending colon going down the left side, and then the sigmoid colon into the rectum.
Okay.
So it just comes up across your body like that.
Okay, so when you perform a colonoscopy, you aren't just looking at the sigmoid colon like sort of like the old straight scopes, like the old sigmoidoscopy. You have a flexible, like a little telescope, like you said, is the diameter of your small finger, and you're looking throughout the entire colon.
Right.
Right into the cecum. Is that true?
Right. And oftentimes getting into the small intestine in short ways.
Okay, so that's important for people to know. So they need to be prepped, and is the colonoscopy done while they're awake? Are they sleepy time, daydream? Are they under general anesthetic?
So we don't do it under general anesthesia usually, but they are asleep. They're usually asleep, and the vast majority of the people do not remember the procedure after they wake up, which is real important because we want this to be as comfortable as possible, because it should be a good experience for them. Because if there are polyps, we're going to have them come back in a few years to do this again, because they'll be at higher risk of getting subsequent polyps. So we want to make it as comfortable as possible.
Okay. Dr. Luba, do you have time to stay for the next segment?
I do.
Okay, great. So we're going to take a little break, but before we do that, I want to make sure it's important that we give out contact information if someone feels like they're due for a colonoscopy or who've never had a colonoscopy, or they're having upper GI problems such as burning or reflux or gastritis or ulcers. Let's give them a contact number. Dr. Dan Luba, gastroenterologist, you're here in Monterey County, right? Can we give out a website or a number?
So we're gastroenterology consultants, and our phone number is 831-375-3577.
Okay, I want to repeat that. Gastroenterology consultants, and the number is 831-375-3577. 3577. Dr. Dan Luba, gastroenterologist here in Monterey County. Please stay with us. We're going to take a very brief pause for good cause. Once again, this is the Doctor Is In television program. I'm Dr. David Morwood. We're coming back with the very important, illustrious guest, Dr. Dan Luba. I hope you'll stay with us. We're coming right back. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline. Welcome Welcome back to the Doctor is in Television program. I'm Dr. David Morwood. I'm a board-certified plastic surgeon right here in the beautiful Monterey Peninsula, California, Central Coast. I'm delighted you could be here, and I'm delighted to continue to speak with our illustrious guest, Dr. Dan Luba, gastroenterologist. One more time as we get started, I want to give out a website or a phone number because we've been talking about colonoscopy, we've been talking about upper GI problems, lower GI problems. So Dr. Dan Luba, Gastroenterology Associates, the number's 831-375-33...
3577.
3577. Okay, excellent. So, Dr. Luba, let's continue our discussion. We're talking about colonoscopy, and I've got 101 questions. So, who needs a colonoscopy? When should they get their first one? Is it covered by insurance? How long does it take? How often do they get them? That's a good start, right? So who needs colonoscopy? When do they get them?
Pretty much everybody needs colonoscopy, and you start getting them at about age 50. If you have a strong family history of colon cancer, you probably want to get it earlier, probably starting at age 40. But you want to get a colonoscopy because we can find polyps, we can remove the polyps, and decrease your risk of getting cancer.
Now, Dr. Luba, now see, that right there is worth the price of admission alone. My previous guest, Dr. Hugh Wilson, we talked about that some people make polyps the way some people have moles, and some people have fatty tumors. We call them lipomas. But the issue in the colon is some of those polyps that are benign can become cancerous. Isn't that true?
Mm-hmm.
Now, Dr. Luba, I have an important question that I'd actually like to know the answer to this. Is it a polyp, just a typical run-of-the-mill polyp that can degenerate and become a cancer, or the polyp or the cancerous growth actually starts as a totally different type of growth? In other words, does a cancer just start to grow, or is it a normal polyp that degenerates?
No, with colon cancer, it is a polyp that then changes into a cancer. So what happens is you have normal cells, they get a couple mutations in those cells, and they start to grow. Those are precancerous. They're not cancers. If you get a few more mutations after that, then that polyp can turn into a cancer. So just because you have a polyp does not mean it's going to turn into a cancer, but if that polyp gets a few more mutations, then it can change into a cancer. So if we find it in the precancerous stage and remove it, it's gone.
Okay, so that's very important information to transmit to our viewers. Let's back up a second. We talked about chronic inflammation leading to probably more polyps and possibly colon cancer. If those conditions are treated, we talked about treating reflux, we talked about treating heartburn, we talked about treating ulcers. If you properly treat ulcerative colitis, Crohn's disease, those conditions that may lead to chronic inflammation, can you decrease the incidence of colon cancer?
Yeah, in those populations, yes. It's where if you have a lot of inflammation, you're going to have a higher risk of getting cancer. If the condition is well controlled, they do better.
Okay, so can we talk about briefly why people get colon cancer, for example? It seems like it's pretty common. As I said before in a previous segment, a brain tumor is pretty rare, fortunately. Primary bone cancer is so rare. But colon cancer, or a cancer of the GI tract, we hear about it pretty frequently. Isn't that true?
Yeah. Well, colon cancer, there's a lot of cells. They divide, they turn over, they're exposed to a lot of things in the environment when we eat, a lot of waste, and you can get a mutation in a cell. If you get multiple mutations, then you can develop a cancer. So that's I think why we see them so frequently in the colon. It has a high propensity to develop cancer. But like, for example, the small intestine generally doesn't get cancers. Not totally clear why that is. But most of the cancers occur in the colon, and we can find them.
Okay. Now, Dr. Luba, I know you're an expert in gastroenterology, and you have a project that you're disseminating or spreading the word about. isn't there a genetic predisposition toward developing certain cancers in the body, and it's in certain populations or certain families' chromosomes, it's in their DNA, that they're more susceptible to developing cancers. Isn't that true?
Yes. If you think about cancer in general, 90 to 95% of cancer is what we call sporadic. So in other words, it just happens. People have bad luck for whatever reason, they get that. But 5 to 10% of cancers are actually genetic or hereditary. And when I was training, and up until 5-10 years ago, we were sort of taught that these were rare. And they're still taught that it's rare. But if 90 to 95% of cancers are sporadic, that means that 5 to 10% are caused by a genetic predisposition. Now, 38% of the population will develop cancer, and we're not talking about skin cancers then. There are about 380 million people in the United States. If 5 to 10% of cancer is genetic, that means that about 1 out of every 25, because 38% of the population will get cancer, that means that about 1 out of every 25 to 1 out of every 50, or 2 to 4% of the population, has a genetic predisposition to getting cancer. There are certain mutations in genes that can be transmitted from generation to generation, and they're at a very high risk of getting cancer. That translates to about between 6.5 and 13 million people in the United States. So when we thought about this stuff as being very rare, that rare number is 6.5 to 13 million people, or 1 out of every 25 to 1 out of every 50 people. That's not rare. And that's why I started Project DNA, which was basically a nonprofit corporation to change the system so that people can be systematically identified. So in other words, whenever you go to see your doctor, they can ask you questions like, do you have a family history or personal history of colon, uterine, ovarian, breast, or pancreatic cancer? It's 5 cancers. And those are really the big 5.
Okay, now Dr. Luba, those are amazing figures and facts that what I think we need to emphasize. So you said about 38% of the population will develop a cancer.
Right. Doesn't mean they're going to die from it, but they'll get a cancer.
Well, that's incredible. 38% of the population will get a cancer of some type. That's amazing. And did you say that about 5 or 10% of those cancers have a genetic predisposition?
Right.
Okay, so if we look at the Central Coast, well, let's look at Monterey County, 350 to 400,000 people, give or take, right? So that means there's going to be a significant number of those 350,000 or 400,000 people who will develop a cancer every year. And some of those will be, let's go over that list again: colon, uterine, pancreas,
breast,
or ovarian?
Yeah.
Okay. Okay, so colon cancer or pancreatic cancer or breast, we said.
Uterine and pancreas.
Uterine and pancreas. Okay, well that's amazing. Okay, so getting this word out, I think, is really vital, and I think what you're doing is really virtuous. So let's emphasize a couple points. So we know that there are certain populations, certain families are predisposed to developing certain cancers, and that's what your project is about, Project DNA. And we know that colon cancer, for example, when it's caught early and treated, it's 100% treatable, curable. Isn't that correct?
Correct.
And now, I want to talk about colonoscopy, and let's take a couple of minutes to talk about other ways to screen for colon cancer. So we know that what we want to do is catch colon cancer early, because
or catch it before it turns into a cancer. So we can prevent it by taking out a polyp in the precancer stage, or catch a cancer before it's spread. I mean, those are the 2 goals. But really, we don't want to find a cancer, we want to find a polyp, because it's precancerous, and then prevent somebody from even having to go through having the diagnosis of cancer. That's really the goal.
That's worth the price of admission alone right there. So the colonoscopist or the gastroenterologist is not only looking for cancer.
No, I
you're
hate
look-
when I find that. That's the worst thing to find.
Okay, so see, this is worth the price of admission alone, right here. This is so vital in terms of public health. So really, what you want to do is find polyps. You're screening for polyps. You take the polyps out. We send them to somebody like Dr. Wilson. You send them to the pathologist. They're examined, and we want to get them out before it becomes a cancer.
Correct.
So that's an amazing effort on behalf of public health. So, okay, so how do we diagnose polyps and cancer early? There's a lot of different ways, right? There used to be, or well, there still is. There's a barium enema. The radiologist can do things.
Mm-hmm.
We can do. We swallow barium, and there's the or the barium enema. There's GI follow-ups. There's something I keep hearing about called Cologuard.
Mm-hmm.
There's colonoscopy. There's the sort of HEMA test, right?
Mm-hmm.
Sometimes I think you can get at the pharmacy. You can get a little strip and test if there's blood in your stool, etc. So Dr. Luba, let's take a couple minutes and go through those. And I need to get you on another segment as a guest. Let's go through those testing types.
Sure.
To screen for blood in the stool or colon cancer or polyps, etc. How about what the radiologist does?
So the barium enema, which is what the radiologists do, has sort of fallen out of favor as a screening test. So we're not really doing that very much at all anymore. There is a virtual colonoscopy that the radiologist can do, and that sort of has mixed results. It's somewhat difficult to do, although we can do basically a CT scan and look at the colon and see if there are polyps, and if then there are polyps, then those people can go back and get a colonoscopy. We tend to do that for people who can't get a colonoscopy. For technical reasons, they weren't able to get it completed. One of the other tests is a FIT test, where you're looking for blood in the stool. Basically what we're trying to do is we're trying to take the whole general population that's at risk for getting cancer and narrow it down to people who are at higher risk, and then have them get a colonoscopy. So a FIT test will look for blood. If there's blood in the stool, they get a colonoscopy. If you do the Cologuard test, that's looking for blood in the stool as well as some abnormal DNA. And if you have a FIT test, again, that suggests that if that's positive, they're at higher risk of having polyps or cancer, so they go for a colonoscopy to see if there are polyps and then remove them. And then the last thing you can do is just go straight towards a colonoscopy and just look and do the procedure, see if there are polyps. If there are polyps, then remove them. All of them ultimately lead to a colonoscopy where we can identify the polyps or the cancers, remove the polyps, or if there's a cancer there, identify it at hopefully a stage that can be treated.
Okay, great. Now, let's back up just for a moment, Dr. Luba. I hear a lot about, on television and magazines, Cologuard. What's that all about?
So Cologuard tests for two things. It tests for blood in the stool, and it tests for abnormal DNA. So if it's positive, then the people are referred for the colonoscopy. So basically, it's about 92% sensitive for finding cancer, and about 62% sensitive for finding polyps. So if there's a cancer, chances are the Cologuard is going to find it. If there's a polyp, it may or may not find it. But again, it's just a way of narrowing the field down to say, you know, who should go to get the colonoscopy. And you know, for a lot of people, they'll say, I'm just going straight to the colonoscopy because, you know, you may not have a positive FIT test. You may not be bleeding at the time because polyps don't usually bleed. So it's just a way of narrowing things down.
Okay, so let's look at we said the population, just for the sake of discussion. In Monterey County is 400,000. So in terms of public health, we want our viewers to know that by the time you're 50, you should have a colonoscopy. Is that correct?
When you're 50, yeah, that's what's recommended.
Okay, now let's say they get a colonoscopy and it's not unremarkable, or it's normal. There's no polyps, etc. Well,
Mm-hmm.
well, actually, let's talk about two scenarios. Let's say you get a colonoscopy when you're 50 and it's normal. When do you get your next one?
10 years later, at age 60.
At age 60. Okay. Now, what if you do have a polyp and you have a polypectomy and it's benign, but you have a polyp? When's your next colonoscopy?
Depends on the size. So if it's a big polyp, we do it in 3 years. If it's a small polyp, we do it in 5 years. And the reason for that is I like to think about it as like fertile soil. So if you go look on the dirt and there's nothing growing there, you come back a year later, chances are there's not going to be anything growing there in a year either. But if you look at this piece of dirt and there's a whole bunch of weeds there, and you pull out all the weeds, you come back 3 months later, chances are there's going to be a bunch of weeds there again. So the people identify who have polyps, who have fertile soil, you need to do them more frequently.
Okay. And so starting at age 50, and then if it's normal, every 10 years. If you have a polyp, it could be in 3 years, could be in 5 years, depending on the size of the polyp. Now, for those families or populations that they know they have some inflammatory disease, like ulcerative colitis, Crohn's disease, if they're treated, do they still get frequent colonoscopy, or do they just every 5 years?
Well, for somebody with ulcerative colitis, after about 7 to 10 years, they then start doing it every 2 years.
Okay.
Because there's still that inflammatory condition. Now, we have some medications that can not only just almost turn it off, and that may change the natural history, but we still don't have enough information to say we're going to just stop. But that may come out at some point.
Okay, so we have about a minute and a half left. Now, I'd want to talk about Project DNA, and again, in summary. If someone's interested in finding out more about Project DNA, where do they go? How do they find out more information? And what if they want to know, they're watching this program and they say, you know, my aunt had uterine cancer, and my sister had this cancer, and my uncle had pancreatic cancer. They want to get screened.
Mm-hmm.
And also, once again, I want to give out the contact information for Gastroenterology Associates, website and phone number, so people can call and get screened if they need to.
So Project DNA is a nonprofit corporation that I have. So the website for that is just projectdna.org. And if you go there and you have and you're concerned about your family history, you can go to Patient Tools, and there's actually a questionnaire. It's a computer questionnaire that you can punch in, and it'll tell you if you meet criteria for getting genetic testing.
Excellent. So projectdna.org. Anybody can look that up.
Right.
World Wide Web. Okay, excellent. Dr. Dan Luba, gastroenterologist. Now, what about the contact information for the Gastroenterology Associates? I may remember the phone number, but what about the website? Do you have a website?
We do have a website. It's just gastroenterologyconsultants.com.
Okay, perfect. And then my guys in the control booth, Michael and Dave, they're going to test my memory. 831-375-3577. Okay, 375-3577. Dr. Dan Luba, gastroenterologist. Dr. Luba, you're a great teacher. I really want to thank you for everything you do. This Project DNA is amazing, and you're going to help a lot of people. It's wonderful. Once again, this is the Doctor is in Television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here on the Central Coast of California. Go to my website, drmorwood.com, DRMORWOOD, or call my office at 831-646-8661 for any information about any area of plastic and reconstructive surgery. Thank you very much, Michael and David in the control booth. I hope you will tune in again. Thanks very much for being here to the Doctor is in Television program.